Hey everybody, Joe Betcher here with the first Ultrasound of the Month video. I'll admit this video is actually a couple months old. It was performed by none other than the good Dr. Michael Boggs. I do have to give Amanda Payton some credit too, as she was there as well. In this patient we performed an echocardiogram because she was really short of breath and very fatigued. You take your phased array probe and you place it towards the right shoulder, and that gives you this parasternal long view. The first thing you should notice is just how wimpy this heart looks. Look at the left ventricle, which is seen right here. This is severely depressed systolic ejection fraction. The more of these you look at, the better you'll become at determining the ejection fraction. The next thing you should see is a small collection of fluid just posterior to the left ventricle. This is the pericardial effusion. The most important thing about this is to know that it's truly a pericardial effusion and not a left pleural effusion. You'll notice that this fluid collection is anterior to the descending thoracic aorta, which means it's a pericardial effusion. If it's ever posterior to the aorta, it's a left pleural effusion. You certainly don't want to go placing a needle into this space when you think it's a tamponade when it's actually just a pleural effusion. Alright, enough of that view. Now you take the probe and you rotate it 90 degrees so the marker is pointing towards the patient's left shoulder. Now we're in the parasternal short view. We're looking right down the barrel of the heart, and in the middle of the screen we see the left ventricle with the two papillary muscles. This is the ideal level to be able to tell the patient's systolic ejection fraction. Once again, just posterior to the left ventricle, we see a small fluid collection that's the pericardial effusion. We'll now take the probe and move to find the axillary view. Your marker is still pointing towards the left shoulder. In this view, now we can see all four chambers of the heart. We continue to see that pericardial effusion that surrounds the heart here. The biggest question we have when looking at a pericardial effusion is if the patient's in tamponade. It's unlikely when the pericardial effusion is small like this. The first thing to do is to look at the patient. Are they hypotensive? Do they look sick? Or are they playing on their iPhone? One of the first signs we'll see on an echo when someone has tamponade is abnormal motion of this right ventricle. It'll almost look like someone's jumping on the trampoline of the right ventricle. We don't see that here. If you'd like to get really fancy, you can take your pulse wave Doppler and shoot it through the mitral valve. You'll see the amplitudes of the E and A waves here. Just like you'll see electrical alternans with varying amplitudes of your QRS complexes on an EKG when someone has tamponade, you'll see varying amplitudes of the E and A waves through the mitral valve. Given these E and A waves all look about the same amplitude, I don't suspect tamponade here. Pericardial effusions can be misleading and oftentimes difficult to see, so we check our fourth view, which is a subxiphoid, and we see the pericardial effusion here as well. The final thing to look at is the IVC. We take our probe in the subxiphoid view and move it towards the patient's head. The IVC will come into view in a long view here. When the IVC looks plump and has minimal respiratory variation, just as it is here, it raises my suspicion of tamponade, although it's not a guarantee. Other conditions, such as heart failure, which is what this patient has, also will show a very plump IVC. If this IVC was completely collapsing with every breath, I'd be much less suspicious for tamponade. Alright, that's all for now. Tamponade is very complex. This is just a very brief intro to it. There'll be more to come later. Nice find by both Boggs and Payton. I'll see you guys next time.